So,
Okay, shall we
yes,
start?
please start.
Okay, so I'm Dr. Fareen, and along with me is Dr. Tayyeba. We are starting the free session for MRCOG Part 3 for the early pregnancy. Okay, so in this we are going to discuss two cases. As this is the first session, so if anyone want to volunteer can come. Otherwise, we are going to explain the basics, how we go and proceed through any of the cases. Not just this case, this will be explained to you one by one that how we can go forward. Okay, so this is my case number one. First, go through the case and then see how we can go through it. Okay, so whenever you are in 2 minutes, when the station starts, first there is a 2 minute. The 2 minutes are very important to see what you have to write it in it. Okay, because it can lead further forward. So this is a simulated patient task. You can write SPT. You have to see which domains are being tested: information gathering, communication with the patient safety, and applied clinical knowledge. This is very important because sometimes there is no information gathering, and then you don't have to ask for the detailed history. Okay. So once you have written this in 2 minutes, most of the time you are in ST5, and you have to have a situational awareness, that is in accident emergency department. Okay. The name of the patient, Steffi Williams. It is very important safety point because when you are communicating with the patient, we often forget the name. So I used to write down the name and age of the patient in my 2 minutes point. Okay. And what are the presenting complaint? Who has come with the complaints of lower abdominal pain and PV spotting? Write it down that when 2 minute point that this is the presenting complaint. See, so these need to be elaborated. Now, what information is given is that pregnancy test is positive. She is extremely anxious. Note it down because when the patient is having like any diagnosis, any concerns which are having, we have to satisfy her. We have to deal with her very patiently. She has just had a TB scan and is waiting for you to discuss that the beta HCG value was 3900. Okay. So what information we got from this case? This is a simulated patient task of Steffi Williams, 35 years of age, and she has presented to us with complaint of pain and bleeding in a department to discuss the scan. Her pregnancy test is positive and the value is given. Okay. Now this is the ultrasound report. And before this has to be studied in detail because each and every finding has to be explained to the patient. I'm just discussing about 2 minute point. Okay. So this is the ultrasound scan report. This is antibody normal size, endometrial thickness 10 millimeter. There's no intrauterine sac. Right and left ovaries are normal. Right adnexal mass measuring 2.5 centimeter. We are suspecting ectopic pregnancy. Okay. And there's a small amount of free fluid in the pouch of Douglas. Okay, these are the scan findings. You can also write it down, but when you're used to practicing, you just remember, but you have to explain each and every point. Okay, next slide. Can we have a next slide? Okay, so in the next slide, there is the next slide. Yes, we have blood test, which is already 3,900 international unit beta HCG. Hemoglobin is 12. Blood group is A positive. Important, but it can be negative also. And the patient is vitally stable. Okay. So, yes. Now, can you please show me the scenario? Okay. So when we are starting with any of the case, just 2 minutes, we are going to write it down. Now, when you are started presenting, the most important safety point is the introduction. So when you are talking to the patient, you have to be very important that I am Dr. Farheen, one of the doctors in accident and emergency department. May I confirm your name and age, please? Because name and age is very important safety point to be asked. So the patient will say, I'm Steffi Williams and 35 years old. So how am I address you? You are going to ask next question because in such cases, there was one scenario which I remember the patient doesn't want to be called by the name. Okay. So we have to ask that which name she wants to be called. So I'm Dr. Faniman, the doctors covering the accident and emergency department. May I know your name and age, please? She will say, whatever the name is, I'm Steffi William, 35 years of age. So how may I address you? You can call me Steffi or anything else. Okay, then you have to lead the discussion. Important in part three is that you have to lead the discussion by saying that, oh, I believe that you are having a low, you have come to an emergency department with the complaint of pain and spotting, and how you coping up with the pain. Now, introduction in the emergency cases sometimes do changes, because whenever the patient is vomiting, whenever the patient is having pain, you have to ask the patient that does she need any painkiller. If we keep on talking patient is severe pain, it is not a important, it's a very important point with the lay examiner notices. Okay, so we have to be empathetic to the patient. Okay, so first of all, we have to do the introduction, confirm the patient's, this we call as eyes, that is introduction, and then we have to ask for the patient concerns and expectations. Okay, so I'm Dr. Farima, doctor serving the accident and emergency department. May I confirm your name and age, please? My name is Steffi Williams. I am 35. How may I address you? You can call me Steffi. Okay, so Steffi, I believe that currently you are having pain and bleeding, and I can see that you have a scan done and you are here to discuss the same. Am I right? She will say, yes, doctor. So how are you feeling right now? Do you need some painkiller? No, doctor, it's okay. Okay, the patient can say both of the options. If she is having any pain, you have to offer her painkiller after excluding allergy. Once you are practicing this station, you will come to know that how the introduction changes. Okay, so do you have has anything been discussed with you before that? So you have to ask the patient, because sometimes the patient know the scan. This will again create some communication problem. Okay, so you need to be have a situational awareness that what is happening to the patient, and what she knows about it. Okay, any concerns and expectation? She will say, no, I just want to know about my report, I'm very anxious about that. Here you can offer the support, but don't worry, we are here for you. But before that, now we are putting the agenda. Okay, first introduction, then then we have the concerns, then expectations, and then we have the agenda. I would like to ask you a few questions before moving forward, so that we come to a safe and mutually agreed plan. And then I'm going to inform my consultant also. Is that fine for you? Okay. Okay, you can change it accordingly. Now you have to take the history. So if anyone wants to communicate, or when anyone wants to volunteer, what will be the history can forward, or I will explain. Anyone wants to discuss it? Okay, let this the first session we can ask. So, first of all, in history of presenting complaint, you have to uh, this abdominal pain and PV spotting. You have to ask about these in detail. Since how long you are having pain? Any factor increasing, decreasing it, any urinary complaint, bowel complaint along with it, any history of faintness, dizziness, or shoulder tip pain. And why I have asked these questions? Because are specifically related to the ectopic pregnancy. Okay. And we can see after the scan that's the next ectopic. So we have to ask about like this, but don't ask leading question. Don't ask close question. Just can you tell me more about the pain? And let me tell you that role player is going to explain all the thing about the pain, and you don't have to ask any other question. And if she misses, you can ask any other question. Okay. Similarly for PV spotting, any factor increasing, decreasing it, or amount of bleeding. And then you have to ask about the pregnancy itself, that she's pregnant, what is the planned pregnancy, unplanned pregnancy, or spontaneous contraception. Is happy to, she's, if she's unplanned pregnancy, whether she is happy to continue with it. Okay, so these are the steps. Then you have to ask about the last menstrual cycle. Last menstrual cycle, we everyone can make their own pattern of history taking, and then we have to go for the according to that. But we have to cover in the history the the main reason for the history is to confirm the diagnosis, identify the risk factor, and exclude other causes. So I have analyzed the presenting complaint as a topic, and now I will be asking in the history about the risk factors, like last menstrual period, regular, irregular. When she will say, I'm 6 weeks pregnant, my cycles are regular, and I'm 6 weeks pregnant. These things, okay. Then we have to ask about any previous pregnancy, first pregnancy or not. If there's any previous pregnancy, whether there is any termination, what was the outcome, any complication, any details about the pregnancy. You have to ask. Just ask, can you tell me details about the pregnancy? She will tell all the thing. Okay. The difference between the open and question is like this. Is it because if you ask close question, it will be very time consuming. Then after that, routine history, and you have to ask about any medical history, any surgical history. Now, medical is important because when you are planning for any treatment, any contraindications to be ruled out, any surgical treatment like previously taken, like patient may have any previous ectopic, previous patient may have any previous surgery, we have to ask about the outcome. Okay. Then we have to ask about the drugs which she is taking, any allergies. Allergy is the very important safety point, because if you're not going to ask, it will you will not be marking pass in the patient safety. Okay. So medical history, surgical history, drug history, allergy would be there. Then you have to see the contraception, because one of the risk factors for the ectopic is intrauterine contraceptive device. You have to ask which contraception was she using. Okay. You have to ask about sexually shared infections. These are all the risk factors. Okay. Then we have to move for the family history is not as much important in this, unless otherwise, unless you see that there is a history. You can ask any significant family history or not. Now, the important is blood group. Blood group is already given, and then you can say, and then it is very important to utilize the information which is already given in the patient. Like, say, you can say, I can see your blood group is A positive. Am I right? She will say yes. So, any concerns regarding the blood transfusion? Okay, so these are the points which you have to ask in the early pregnancy. It is very important. Then again, you have then smoking, alcohol, and recreational drug abuse. Smoking is one of the risk factors, so you have to ask about it. And you can before that you have to do the signposting before sexually shared infection also, and before this also. Okay, so you have to, may I ask you some personal question? Don't ask multiple questions that may I ask, may I ask. Just simple, be brief, and ask about it. When you are practicing it, you will be very quick in it. Okay, and you can also ask for support. Now, support is not always necessary, but in this case, when we are suspecting some difficult diagnosis, we need some support, because empathy and sympathy is very important in part three. And you have to be very polite to the patient. Okay, now information gathering is completed, and you have to target your information gathering in 3 minutes. When we'll be posting this scenario, we'll be guiding her. Then history, then examination, then investigation. Okay, so after that we have to when we're starting with the investigation, we have to say that you have someone with you. Okay, she will say no. So can I continue? She will say yes, you can continue. Okay, then we have to, most important safety point is the name, age, and NHS number of the patient. Before every report they will be given. If even not given, you have to say that. Okay, then can we have the ultrasound report, please? Okay. So, yeah. In ultrasound report, after confirming the name, age, and NHS number on the report, I can see that there is no evidence of intrauterine pregnancy, and you can say that the right and the left ovaries are normal. There is a small amount of the fluid. You have to explain this, why this fluid is there. It can be an early, because can be an early rupture of ectopic. Okay, so you have to say that. I don't have a good news for you. The ultrasound shows the presence of a pregnancy outside the womb, inside the tube. See, I have lowering down my voice. You have to be empathic in this. And this is called as ectopic pregnancy. Okay. Then you have to explain what is ectopic pregnancy. You have to quote what are the risk factor in her case, because scenario can change every time. And then we have to give the options to the patient. Okay, this is the sequence: history, examination, investigation, ectopic, it causes, and then management. Now, when we are coming to the management point, we have to say that there are three forms of management of ectopic pregnancy: conservative, medical, and surgical. Okay, the conservative management is not an option for you, so we can proceed with the medical and surgical. Do you have any preference? She will say no. Okay, so then you have to explain both. If she say medical, then you have to explain the medical. And what is the medical? That is the methotrexate. You have to then say indications and contraindications of the methotrexate in it. You have to say that, well, you have to, most important point is the contraindication, because these are the safety points. And in that, you have to just mentioned what are the like you have to avoid alcohol, drug exposure, sun exposure. You have to get well hydrated, and you have to have a contraception for 3 months. Okay, so then after explaining, then if we want surgery, then you have to explain in detail. After that, you have to ask. So for all these, we are going to inform our consultant. We need to admit you in the hospital for the further management and investigations. We may repeat your pregnancy test, and then your full blood count, your blood test, and liver function test, and we'll start with the medical management. Okay, so after that, you have to during this admission, you may feel pain, you may develop dizziness. These are the red flag signs. Okay, red flag sign whenever the patient get admitted or not, you have to explain to the patient, because she has to report to the 24-hour contact service, and patient information leaflet would be given in it. Okay, and you can, I always use remember consultant, counselors, and support group. Please remember this and write back to GP. These are the loop which have to be finished. I'm going to inform my consultant, write back to your GP, give you the written information as well. The other red flag sign, if you develop any of these symptoms, please report to the 24-hour contact service. And once again, I'm very sorry for that. Okay, so when you, this is the whole scenario which you are going to continue. Okay, if anyone has any question, please tell me, because when you are presenting, it will be very different. Anyone has any questions? So please ask. Okay, so information gathering, you have to ask about the ectopic pregnancy, the risk factor, and exclude the cause. In the patient safety, important to admit the patient, explain the red flag sign, contraindications of methotrexate, and also you have to support regarding the future pregnancy. Okay, you have to tell that in future there is a chance that you can conceive. Okay, so can we proceed to station number 2 if no one has any question?
Okay, Dr. Farheen. Now
Mhm.
let me start my station.
Yes,
And it
okay.
was, I will must say that you had given a very well brief about your whole scenario. And once the candidate will go to listen it, they will be able to perform the early pregnancy module in a very easy way. Thank you, Dr. Farheen.
Thank you.
Now it's my turn. This is my station 2. Dr. Farheen has already explained you that how you will come across a station. This would be just like a in this form. See, again, we both had chosen simulated patient task because in exam, when we came across a patient in front of examiner, our presentation is much different than we are rehearsing at the home. So we both had chosen these tasks for the simulated patient task and not instead of structured discussion, because when we are talking to the examiner in medical jargon words, it's very easy to perform. But when we are facing patients and we have to give them brief in a layman language, it would be difficult for us. So we have chosen these tasks, that is simulated patient task. The same task can come in your exam because we both had chosen the recalls. See, the first four lines are very important because every task, either it's a structured discussion or a simulated patient task, we all have a following test: information gathering, communication with colleague, patient safety, and applied clinical knowledge. So it's important for any task to be solved according to the domains of MRCOG Part 3 assessment. So keep in mind, this is not theoretical at all. This is totally practice exam. And this scenario will be in front of you. You will be given 2 minutes just to read. As Farheen told you about three important things to be learned from the scenario. First, be patient when you are going to look at your scenario. Don't hurry because these 2 minutes will make you aggressive during the exam. And do not waste these 2 minutes. Okay, turning your pages, first go through these four lines. See, the scenario has been written, the ST5, you are always be behaving as a ST5, not as a consultant. So you have to know your basics, not jump to the management. Okay, so Amanda Jam says here 26 years, name and age important, Then the scenario is of the amenorrhea 7 weeks. She is here to discuss with you the management plan, and on her report, you are having her HCG level, that is 1023. Again, whenever you are going to read, one thing in your mind is early pregnancy. Okay, early pregnancy you got, and you have just to switch on your guards on early pregnancy, because you have to jump here and there in the exam. You do not get a single minute of a break. So this scenario can come in between after gynae module. Even this scenario can come after the labor board. So be present of mind is very important in this exam. See, the next slide is going to the scan. Again, a scan is there. It's mentioning that 9 into 7 into 1 intrauterine fluid collection is there. Anechoic with and angular margins are there. Slightly centrical cavity located. No evidence of double decidual reaction. And then again, they will say that no intrauterine pregnancy, thickened endometrium, prominent right ovarian cystic lesion is compatible. No free fluid in the cul-de-sac. That's showing that must be possible. You're not able to read it all. Just focus on the basic points. What are you going to have from the task? Got it? So the findings suggestive of PUL, that is pregnancy of unknown location, most of the time it's not mentioned there. Dr. Farheen just, had made this presentation and she just wanted not to scare you. Therefore, she had mentioned this point. Findings are suggestive of PUL, pregnancy of unknown location. She is vitally stable. Blood group is A positive, and her HB is 12 gram deciliter. Very important investigation finding is there. Now scan is there, and come back to the scenario. Scenario you had kept in the mind that 7 week pregnancy with beta HCG level. She is having no complaint, but she is here. She is not having any spotting there. She is not having any pain there, but she is there to discuss with you the management plan because GP has referred her to you. So again, the safety point. First, you will introduce yourself to the patient that you are a doctor there to discuss about her management plan. Then you will again ask from the patient that what's your name and your age. Then you will make rapport with the patient by again repeating the task in front of the patient. You have to say, that I am Dr. Flana Flana. I am there to discuss with you about your case. For that, you have been referred here to the GP, from the GP. After that, you will come to the history. Focused history would be there. Okay? Focused history to be there would be there. Starting from the pregnancy, and you have to ask that is this pregnancy is planned or not. Even you can ask that any specific concerns from your side from the history might be possible. Patient will take you to the management directly, and then you have to make rapport with the patient by asking that is it possible, can I ask some questions from you so that we can make a management plan because we are meeting for the first time. Then the patient will allow you to talk with her. Again, the focus history of the early pregnancy. What can be the focused questions for your patient? That is it a planned pregnancy? Are you okay to talk with me? Okay. Can you tell me more about any symptoms you are having? Any nausea, vomiting? When you came to know about your pregnancy? Have you felt any faintness at a home? What about your cycles? Are they regular or not? Have you encountered any pain and bleeding in this cycle? Have you been pregnant before? Then come to the normal routine. These 5 to 6 questions are enough for this task. Because if you will take more and more history, you have to get the answers from the patient, and your history should not be completed in a given time. And then you will not jump into the management, you will not jump into the plan, and you will lose the time. Okay. So after that, you will ask medical history, surgical history, and signposting is very important. What is signposting? Actually, you have to make a rapport and safety of the patient like this. If you don't mind, I am having some personal questions. This is the line you have to learn, okay? Uh, uh, if you don't mind, I have some personal questions. Can I ask? Then you have to ask in a line, that have you and your partner been screened for any sexually shared infections? Okay, do you smoke? Take alcohol? Can you tell me about your BMI, your weight to height ratio? And then you can proceed further. After the history, you have to thankful to the patient. Thank you for your cooperation with me. Now I am here and I will discuss with you your report. As in the previous scenario, it's been told to you that confirming the name and NHS number is very important. It carries the marks of a safety. You have to tell patient that I have gone through your report and I have confirmed your name and NHS number, and I came to the diagnosis of pregnancy of unknown location. Then you have to explain it in your own words, that what does it mean. Sometimes the patient rush to the diagnosis. Patient do say you, doctor, what do you mean that I'm going to miscarry? Doctor, what do you mean I'm not having a normal pregnancy? Then you have to normalize her attitude with you. You can offer her a glass of water. Even you can say that if you want to call someone to be with you, so that you would be more comfortable, she will, even most of the time she will reply you no, but she will be comfortable with you on talking. Okay, so you have to explain that your UPT, your pregnancy hormone test came as positive, but ultrasound is not giving us a clear picture, so we are saying it actually it is a pregnancy of unknown location. But at present your pregnancy hormone level is low. We will going to monitor it further. Okay, as you all are knowing theoretical, that what is the management of pregnancy of unknown location. You have to repeat your beta hcg in 48 hours, but you should speak this in front of patient. Okay, then you will give the management option. What could be the plans for pregnancy of unknown location? You will tell her that it can be a miscarriage if your pregnancy hormone levels will fall down. It can be ectopic if your pregnancy hormone level may be plateau, and then we will repeat your scan. And it can be, we can say that progressive pregnancy if your hormone level will raise to double. Okay. And each and every aspect is explained in layman language. For this, we are having patient information leaflet. We will go through it. Okay. So whenever you are going to give a possibility of every option, likely you are saying that it's a miscarriage, then there and then you can ask from the patient, have you got my point? Let me explain it further, because it will this is a long scenario. You have to explain it in a very well way, not in a rush way, but you have to come to the conclusion also. Okay, miscarriage, ectopic, and then progressive pregnancy. For that we will monitor her beta hcg level. Okay, then you can ask from a patient, can I explain you more? Then you can give the percentages level. If your beta hcg or pregnancy hormone test comes 63%, then we could repeat ultrasound from your down below. Even if your pregnancy hormone level will touch on 1500 level. Okay, and if it's falling more than 50%, then it could indicate miscarriage. What could be the possible option of the miscarriage? What could be the benefit? We It doesn't mean that we have to explain about the benefit and the side effects about the treatment of the miscarriage. We will just touch the miscarriage topic and then we'll come back to our scenario. Okay, then if it's a topic, we will do this. Okay, after explaining these all to your patient, then you will come back to the scenario of now. You will never leave her like this, that these are the options and the time is finished. No, you should get at least 1 minute to come her at present situation. What are your views? You can ask from the patient, are you ready? Can I get your admission done for the further monitoring? And if she's saying to you that no, I'm not ready at the present, then you will say her about the red flag signs. Okay, and the red flag signs you have to mention, that if she will encounter any pain, any bleeding, 24 hours contact number you have to provide. You will book her appointment with the consultant. And see, in this whole task, you have to also tell to the patient about communication with other team members. because you will involve this, you will involve that senior midwife in your case, you will involve your consultant, you will involve your scan doctor also, lab doctor also, so that to proceed and to come to the conclusion of this case. Okay. So, if the patient is leaving you, then you have to provide information leaflet. And if the patient is ready to get her admission done, then there and then you will clear your patient that I will ask my staff nurse to help you out to fulfill all the formalities of admission. Okay. And if the patient is RH negative, it's very important to tell the patient about, sorry, about the injection program. That's very patient safety important point. In this scenario, early pregnancy module should need the history. In the history, also the blood group, and the end. If she's RH negative and it's mentioned in the scenario, you have to tell that you are RH negative. This blood needs some injection so that to avoid other complications in the next pregnancy. At the end, you have to say, sorry, sir. You have to say thank you to the patient, and same leaflet to offer the patient information leaflet, and then you will end the session. Anyone else who wants to discuss about this case? Okay. So we had summarized, I will just summarize the motive and main aim of this session. That Dr. Farheen and me just wanted to have, that just to give you the basics of part 3 exam. We had put 2 scenarios there for you. And in the next session, we will be taking we will continue these free sessions for you so that you people can come up and do practice with us. We will be giving 2 scenarios in each session, and whoever will be the volunteer will speak to us. We will record their scenarios for 10 minutes and we will give the feedback. But for now, you people were not prepared, so that we had just summarized our cases with you, that what actually you will be facing. Don't forget 4 things whenever you are going to prepare for the MRCOG Part 3 exam. That is information gathering, that is patient safety, communication with patient, communication with colleague. Very, very, very important. Then comes to the applied clinical knowledge. Applied clinical knowledge carries 100% marks in MRCOG Part 2, but it is just a portion of Part 3 exam. So going through multiple theories, but you are not able to speak in front of examiner or in front of patient, means that you had not been prepared for the exam of MRCOG Part 3. Therefore, we are taking these sessions for you so that come up and speak up and get the feedback so that you will be able to perform best in your exam. I thank you all who had joined, and who had not joined. I hope that they will join in our next session. That will be from different module, might be possible from the subfertility. We will be, inshallah, we will be giving you the scenarios there in the next Friday session. Okay, Allah Hafiz from our side.
Thank you, Dr. Taiba, and thank you, Dr. Faheen. It was really a very nice session, and we are looking forward for such nice sessions more in coming days. Thank you very much, audience, for joining us.
Thank you, ma'am.